Good morning, everybody, and this is Mrs. K coming to you to talk to you about perioperative nursing. What a great career I've had because this is one of the things that I have done in my career, and I totally enjoyed it. And I learned so much from so many different people and met lots of great anesthesiologists and surgeons and nurses and surgery techs. So I am excited to tell you about perioperative nursing. So usually when we think of perioperative place, we don't really think of everything that goes on behind the scenes. We just think about OR, like there's the surgeon doing the operation on a patient, and there might be some other people in there. Well, that's not how it is. There are so many other people involved with the surgical process. So that is what I'm going to tell you about. I would like to say also that I have posted videos about each area, sterile processing, or what I call sterile processing, pre-op, intra-op, and post-op. There is a video, very short video, on each of those areas. I recommend highly that you look at those because it's just like being there. I really like the videos. They're short. They're maybe probably the longest one is 5 minutes, but they're mostly about 2 minutes long. So please watch those. Since you're not getting to go to a clinical area, it'll make you feel more like you are in a clinical area. So pre-op, pre meaning before. So that's when we give the care before and get the person ready. Intraoperative, intra meaning inside. So inside the surgery area. And then post-op care, which is commonly referred to as the recovery room, but we like to call it the post-anesthesia care unit. So one of the huge things that we have to think of when we think of surgery is that, our patients are depending on us to keep them safe. They are asleep. They are unconscious, and we have to take care of them within the surgical suite. But in order for the nurses and doctors in the surgical suite to take care of a patient appropriately, the preoperative nurse has to do his or her job, they have to do their job in the preoperative area, taking an appropriate history, that sort of thing. Like we have to know in the OR, what allergies do they have? What is their past history? All of those things are so important when we are operating on people. So are we being safe? On page 1026 and 1027 in your book, there is a list of organizations that try to make sure that we are safe in healthcare. With this particular part of nursing, there is the Association of Perioperative Registered Nurses, or AORN, that the perioperative safety is one of the 4 domains under which that organization organizes its perioperative patient outcomes. So you might think that just nurses on a hospital floor make up care plans, but that is not true. The nurses in the operating room also have to have a, they have to do a care plan on their patients as well. And one of the big areas for those nursing diagnoses is safety. They focus on safety a lot of the time. So with that being said, I want to talk to you again. I think I've talked to you about this before, but I want to talk to you about things called never events. Never events are things that should never happen. Again, our patients rely on us, and these never events are highly preventable. So we need to pay attention to what we are doing. We have to be very diligent in what we do because patients are depending on us to keep them alive while they're under our care. So never events are serious and they're costly errors, and they have severe consequences for our patients. So just some of those that I can list for you. They're also in your book on 1027. Surgery on the wrong body part. Surgery on the wrong patient. The wrong surgery on a patient. Surgical site infections after certain elective procedures. Deep vein thrombosis, pulmonary embolism after a total knee replacement or a hip replacement. And something that is probably more common than it should be is foreign body left in a patient after surgery, like an instrument is left in there, or a surgical sponge or gauze is left inside the patient. And they are, sewn shut by the surgeon, and then they leave the OR, go to the recovery room, go home, and maybe have pain or other complications later, and come back, and lo and behold, they do an x-ray, and there is a hemostat or something that was left inside. And I'm not laughing because it's just really sad to me. But it does happen, and it can definitely happen. So that is, again, why we have to be very diligent in what we do. And in the operating room, there is a lot of counting going on. And again, I recommend highly that you watch those videos that I put in your module. So perioperative nursing. Surgery is the art and science of treating disease, injury, and/or deformity by operation and instrumentation. So all that's saying is the doctor uses instruments and he performs an operation or a surgery. And we're going to talk about why surgeries are performed. So again, when we think of the surgical suite, the surgical suite is basically the operating room, but there is a lot more that goes on besides just the operation. Operating room nurse is an old term. We refer to quote unquote the operating room nurses as perioperative nursing. Perioperative nursing includes all of those different areas: pre-op, intra-op, and post-op. So there are nurses that strictly do pre-op care. There are nurses that strictly do operating room, and there are nurses that strictly do the recovery room. Some nurses do all three as a model, a different model of healthcare. They get rotated through each section. And that's kind of what I did, and I totally enjoyed that. My favorite area was pre-op because the patients are just coming in. They have a lot of anxiety. I like to listen to people, so um, I was good at taking histories and things and starting IVs, so I liked the pre-op area. Not necessarily more than the OR, but I really did like them. I liked working there. So pre-op, before surgery, intra, meaning inside, during surgery, and then post-op, after surgery, in the recovery room or in a hospital room. And there's the organization again, the Association of Perioperative Registered Nurses, that has a set of standards that guide their care and their practice. Um, and they're pretty stringent. They're pretty diligent at what they do. Here are some suffixes that I want you to become familiar with. They're not necessarily, you're not going to be tested on them, but you'll be tested in your life on them. Like when you look in the chart and you're going, okay, what does this mean? So again, medical terminology, I can't stress enough how important it is to know that. So I'm just going to go through a few of these, a few of the suffixes that are common for surgical procedures. So an ectomy is an excision or removal of. So what do you have on your body that can be removed? Well, practically anything. But I can think of, just off the top of my head, tonsils. So it would be a tonsillectomy, removal of tonsils. Or some ladies might get their uterus removed. That is a hysterectomy. Ovaries removed is an oophorectomy. So that's several. Lysis is a word within itself. I can't off the top of my head think of a OR term with lysis as a suffix, but there is something known as lysis of adhesions, which is a surgery in itself, where a surgeon would go in and cut loose tissue that has grown other tissues or organs together. So the adhesions remind me of, if you've ever seen, I don't even know what the movie is because I don't watch horror movies, but Freddy Krueger, I think, had a lot of like scar tissue on his face. That's what that reminds me of. Like the tissue is grown together by these strands, and the surgeon will go in and cut them so to relieve pain or whatever other symptom a patient might be having. So as a suffix, what I'm thinking of right now is hemolysis, which is destruction of red blood cells. Orifice is the repair or suture of something, and what comes to mind to me is herniorrhaphy. So someone that has a hernia and the surgeon is suturing it up to repair it, or repairing it, I'm sorry, that is called a herniorrhaphy. An oscopy is looking into something commonly done is a colonoscopy, not a colonostomy. I've heard people say that a lot, and that is not correct jargon at all. So it's an oscopy, looking into with a scope. Bronchoscopy is when a pulmonologist or other doctor would go down into the lungs by way of the bronchi and look into the lungs by way of the bronchi, I'm sorry, by bronchoscopy. An ostomy is a creation of an opening. So a colostomy is a opening into the colon. You've already learned that. Urostomy is creation of an opening for urine to drain out. So those are just a couple. Otomy, O-T-O-M-Y, is cut into or incision of. And what comes to mind is craniotomy, into the skull, maybe to release pressure or to do some type of surgery. Plasty, repair or construction of. Rhinoplasty, rhino refers to nose. So a rhinoplasty is a nose job. Classifying surgeries, we can do that in different ways. And one is by the body system classification. So we have surgeons that we refer to basically by whatever body system they work on. So we have cardiothoracic surgeons. They work on the heart and they work on the chest and lungs. We have orthopedic surgeons that work on bones, and there are, we have neurosurgeons. We have, all different kinds of surgeons. So, based on body system. Body system classification is useful for determining a postoperative risk of infection. Surgical incisions that enter the GI tract or the respiratory tract or the genitourinary tract have a higher risk for infection than a surgery of any other body system, just simply for the fact that our GI system, we have a lot of bacteria in our colon. Respiratory system, we tend to, we're breathing stuff in. And we have a mucous membrane, our mouth, and then our pharynx, larynx. So we have the respiratory system has a direct line to the outside, not just the surgical incision itself. So again, a body system can be used to determine how high of risk the surgery is. So then we can classify surgery by purpose. Any kind of ablative surgery involves a removal of a diseased body part, like a cholecystectomy, cholecystectomy. So chole refers to like gall, and then cyst is bladder, and then an ectomy is removal of. So that's removal of a gallbladder. So removal of a body part. Cholecystectomy is just one example of that. An ablative surgery should be like a curative surgery. Diagnostic or exploratory surgery is done to rule out a diagnosis, like a biopsy or a cardiac catheterization. Palliative surgery is performed to relieve discomfort or other disease symptoms. It does not produce a cure. So, surgeon can take a person into the OR and, let's say, destroy their nerve root or a nerve root to someone's hand so that they don't have a pain anymore. So that is palliative surgery. Reconstructive surgery is performed to restore function. For example, an orthopedic surgeon will do a rotator cuff repair or a torn ligament repair. That's reconstructive. Transplant surgery replaces a malfunctioning body part. The other part that goes with that is the procurement surgery, where you get an organ from someone to transplant in someone else. So transplant and procurement go together. Then there is constructive surgery, where this is a form of cosmetic surgery, where they can construct like a breast for a woman who's had her breast removed. So constructive, or possibly cosmetic surgery. Another way we classify surgeries is by the degree of how urgent they are. How bad do people need their surgery? If it's an emergency surgery, they need an immediate surgery. So there can't be any delay in the surgery. They need it right now. So it requires transport to the operating room as soon as possible to preserve the patient's life or their function. So there is always a surgical team on call at any given hospital. And when they're called in, they have to get there. And they have to do it fast. Urgent means that it should be done within 24 to 48 hours to alleviate symptoms, or maybe repair some type of body part, or restore function. Elective surgery is performed when surgery is a recommended course of action, but the condition is not time sensitive. So the patient can delay surgery to gather information. Maybe they have to, or they want to put some different life things in order, like, getting a living will, all that type of stuff, or getting things in order and getting prepared at home to have the surgery and come back home and have the surgery. So there is time to do things. It's elective. It doesn't need to be done right now, even if at all. All right, so an elderly woman fell at home and fractured her hip after being admitted to the hospital. The nurse knows that the patient is to be stabilized prior to having surgery. This surgery would be classified as, which one do you think? Is this life-threatening? Is it curative? So they want to stabilize her before going to surgery. So if she's going to be stabilized before going to surgery, it must not be an emergency. But is it elective? Can she put this off? No. So this patient will most likely have her surgery within the next 48 hours. It needs to be done to restore her joint function. So it is an urgent surgery. All right, then we go to the degree of risk associated with surgery. So I like that they put this in your book. I hear this all the time. There's an old adage that the only minor surgery is somebody else's surgery, and that is so true. It doesn't matter how, quote unquote, small your surgery is going to be. people are still very anxious about going into the OR or being cut upon. So I thought that was good that they put that quote in your book. So surgery is defined as major or minor based on the degree of seriousness or risk associated with the procedure. So a major surgery is associated with a high degree of risk. It may be associated with the potential for significant blood loss, involve vital organs, be prolonged or complicated, or have significant potential for post-op complications. That is a major surgery, like heart surgery. You know, they're cutting into your heart. Minor surgery is often performed on an outpatient basis. It involves little risk and usually has few complications, such as carpal tunnel syndrome surgery, something like that, release of carpal tunnel. Where are operations done? Surgeries can be done on an inpatient basis, and the patient's hospitalized for surgery. There are a lot of same-day surgery centers, though the person is admitted and discharged in the same day. There's outpatient surgery where the person is not hospitalized. They're admitted to the surgical suite or a short stay unit. A short stay unit is a surgery center. It's an ambulatory center, and no overnight hospitalization is required. Then hospitals have short stay units where persons do stay in the hospital after surgery, but their stay does not exceed 24 hours. I'm not sure that that's necessarily in your book, but. So how do they determine where a person is having the surgery? Well, they have to think, what is the extent of the surgery? Like when I worked at JCMG, we didn't do heart surgery there because we didn't have the facilities. There weren't hospital beds. So the extent of the surgery to be performed, that's a big surgery. So yeah, that was not one that was going to be performed in that type of setting. Possible complications that could arise. So again, just going with the heart surgery, you're not going to be performing that at a same-day surgery center or an ambulatory center. Just can't be done or should not be done there. And then what's the patient's general condition? So if a person has a lot of other issues, like they're diabetic, they have high blood pressure, they have COPD, etc., that is not a good place, an outpatient center is not a good place necessarily for that person to have their surgery. So all of those things are considered. So an ambulatory surgery center provides people with either general or local anesthesia. The surgeries are usually less than 1 hour in length, and they require less than 2 hours in a post-anesthesia recovery unit. Again, does not require an overnight stay. Big advantages of ambulatory surgery is that it's convenient, the scheduling is flexible, it's of less cost to the patient and the healthcare system itself. There are fewer lab tests required, fewer medications required, preoperatively and postoperatively. There's usually less stress on the patient and less likelihood of some type of infection occurring postoperatively. So factors contributing to surgical risk. As this says, it's on page 1028. So as usual, it's usually the elderly people and the very young that are at more risk during surgical procedures. Infants have limited ability to regulate their temperature, and they have immature immune systems, cardiovascular systems, livers. So, that age group is not going to be done at a surgery center. There are children, when I worked at JCMG, I mean, we did surgeries on young children, but never an infant to my knowledge, at least when I was working there. Toddlers understand simple explanations, but can be anxious about being separated from their parents. That was probably when my first week in the operating room, we did a lot of ear tubes on children, and I almost had to quit because I couldn't stand the little kids crying when we took them back to the OR. It was sad, but so that's something that you have to keep in mind if you're going to work in that kind of area. Preschoolers fear damage to body parts. Fear of pain or of needles is common for children of any age. And that goes for adults too. Teens might fear disfigurement resulting from scars. Young adults are anxious about the cost associated with hospitalization or surgery. Older adults are at increased risk because they have less physiologic reserve and often have comorbid conditions, which means they have comorbidities. That's like I was saying, they're diabetic, they have heart disease, they have hypertension, they have COPD, etc., etc. So comorbidities, that is more common in older adults. So they are definitely at more risk for surgery. Type of wound. Both pre-existing wounds and the wounds created by the surgical procedure can pose a risk for infection, which so pre-existing conditions, already talked about that. The ideal surgical candidate is going to be a young person, a healthy person, and somebody who doesn't take any medications whatsoever. So keep that in mind as well. Mental status. Definitely mark this down. Patients with altered cognition, altered thought processes, may be unable to comprehend pre-op instructions or give informed consent for their surgery. They may require antipsychotic medications, something to calm them down, that interact with the anesthetics and analgesics that are to be given in the pre-op area and in the OR. So this whole surgical process can affect them and aggravate any kind of pre-existing confusion that they have, and it can just make things worse for people. Medications. Certain herbal and alternative medications can increase the risk for cardiac arrhythmias because of potassium loss, interfere with metabolism of anesthetics because of their effects on the liver, increase the potential for excessive bleeding, decrease blood flow to the brain, cause high blood pressure, or increase the effects of opioids and other stimulants. So this again is why it is so important in the perioperative area that we who work in the pre-op area take an extremely good health history. It's very important when people are going into surgery. What is their past medical history? The nurse's role in we prepare the client for surgery, assist with assessment during surgery, and help prevent complications and help in the recovery process of the patient as well. So what are the responsibilities of the nurse? Again, it's going to be depending where he or she works. So in the pre-op area, again, not only is it good health history taking and assessment skills, but screening tests. You always have to look at whatever kind of lab work the person has had. You have to look at the EKG, especially if they have a history of heart disease. And one thing I would like to point out here on this slide particularly is the surgical consent. It says confirm its presence. It does not say that we are responsible for that surgical consent, because we are not. The surgeon is responsible for the surgical consent. So what a surgical consent is, I know when you think of a surgical consent, you might think of the piece of paper that the patient has to sign. And that is a very important piece, that paper gets signed by both the patient and the nurse witnessing that they did sign the consent. But the actual consent comes when the surgeon, it's actually professional standards and law that requires the surgeon to obtain the patient's informed consent. So the signed consent form verifies that the surgeon and the patient have communicated adequately about the surgery. So once that piece of paper is signed and witnessed, the consent form is part of the patient record and accompanies him or her to the operating room. But again, the surgical consent means that the surgeon has talked to that patient. Now, if a patient has questions, like a lot of questions before surgery, the usual process is anyway that the surgeon would come in to see the patient before they go to the OR. But if that doesn't always happen in the hospital. If the surgery is scheduled, the surgeon usually heads to the OR in the morning when they get to the hospital, because they know they're going to have procedures. Sometimes they will go visit with the patient who is an inpatient beforehand, but not always. So again, another thing just to keep in mind. But if that patient has a lot of questions and has misgivings about going for that surgery, you need to call the surgeon and tell them. Now, if the surgeon has already talked to them and you've seen them go in and talk to the patient, or somebody has communicated to you that the surgeon has done their duty to, instruct that patient and get the informed consent, then, you can co-sign that or witness that consent from that patient. Now, some patients do, and I will tell you that they will ask you sometimes your opinion. Well, do you think I should have this surgery? And that is, your response should be, well, that is your decision to make. That is not my decision. I just, as a nurse, I just want to make sure that you know what, is going on and that your questions are answered. We don't ever give advice to people, even though sometimes they would like for us to give them advice. So other pre-op nursing responsibilities, I've already said about completing that nursing history, the health history, and making sure that the person understands what they're undergoing. That is of utmost importance, both of those things. So the health history needs to include a lot of different things, or the assessment, the total assessment. Their health history, their mental status, their physical status, what is their culture, what are their spiritual factors, what religion are they, do they want a priest, or if something goes wrong, all of those things come into play. What are their allergies? Do they have access to social resources once they get out of the hospital or once they go home? Can they cope with the stress? Because surgery is stressful. Do they use alcohol? Do they use drugs, illicit drugs? Do they take medications or herbal products or over-the-counter medications? And do they know and understand the surgery and anesthesia? The surgeon, again, will come and talk to them. The anesthesiologist also visits with the patient before, because the anesthesiologist is the one who prescribes preoperative drugs or medications and gives the medications in the operating room to put the person to sleep. Physical assessment, we want to focus on symptoms that indicate a risk for surgery. If you identify risks from the nursing history, focus on those aspects during your head to toe physical assessment. For example, if a patient states that she had a cough last week, your antenna should go up and you should focus on the ears, nose, throat, and lungs to determine if that person has adventitious lung sounds. Do they have, sinus issues, all of those different things. And you're going to want to report if they do to the anesthesiologist, because you have to remember that the anesthesiologist or the certified registered nurse anesthetist is responsible for that patient's airway and breathing and circulation during the procedure. So very important stuff. They rely on us. The nurse is completing a preoperative patient assessment. Which finding indicates the greatest risk for the development of a postoperative complication? The patient is 60 years old. The patient's blood pressure is 130 over 88 millimeters of mercury. The patient does not understand the surgery. The patient has early stage Alzheimer's. What have I said? Which one of these persons has the greatest risk for development of a post-op complication? So the answer was D, the patient that had early stage Alzheimer's. The surgical experience may exacerbate any type of dementia. Even in the early stages, a patient with Alzheimer's may not be able to comprehend written or oral directions related to care. In cases of major surgery, the patient with dementia may pull at dressings, drains, and IV lines and be at increased risk for falls. Another responsibility that we have as preoperative nurses is to complete pre-op teaching. My plan is to put a PowerPoint together specifically for that, just pre-op teaching. So, and I later on in this, I'll mention some of those some of those things that we need to teach people. So you want to give them printed material about the procedure. The doctor, the surgeon's office may have already provided that for the patient. You want to discuss post-procedure processes, like is the person going to be home? Are they going to be hospitalized? And one of the pre-op teaching that needs to be done is teaching your patient how to turn, cough, and deep breathe. Remember that they're not going to be wanting to get up and move around as much as they usually do. So immobility increases the risk for pneumonia and other complications like deep vein thrombosis. And the lung issue is the big thing, so we always want them turning in bed, being at least that mobile. But the deep breathing and coughing exercises are of utmost importance to prevent pneumonia. There's also a device called an incentive spirometer, and I have a whole into Nursing 230 Canvas modules. There is a whole section on oxygenation and circulation, and there are videos in there about devices that can be used post-operatively, and I will include that in my other teaching PowerPoint. So other things that we have to do as a pre-op nurse is prepare the client physically. So assess their NPO status. When was the last time they had anything to eat or drink? People who are going to surgery, especially those who are having a general anesthetic, should not have had anything to eat or drink for the past 24 hours. Prepare the skin. Sometimes, depending on the type of surgery, patients may be asked to shower or scrub the surgical site before they ever come. Like if it's an outpatient, they may have to scrub the surgical site with soap or an antibacterial solution like chlorhexidine or betadine the evening before surgery and the morning of surgery, because studies demonstrate that this reduces the bacterial colonization on the skin. But those studies don't clearly prove that it really truly reduces surgical infection, but I guess it can't help. Or hurt, I mean, can't help, can't hurt. So bowel preps. Some surgeries may require enemas. Enemas are primarily used for surgical procedures of the colon, not for all surgeries. So to empty the colon of feces, patients are asked to consume a low residue diet for several days and then are given a regime of medications and or enemas to clear the bowel. So if the person is having some time of bowel surgery, we as preoperative nurses have to stress the importance of that person, or to that person, that they need to adhere to that those recommendations to decrease their risk of contaminating the operative site with feces. Very important. Facilitate an empty bladder. Indwelling catheters are not routinely inserted for surgery. So if you are a preoperative nurse, before the patient goes back to the operating room, you should always have them empty their bladder. Catheterization may be prescribed if it is important to keep the bladder empty during surgery. If they know for sure it's going to be a long surgery, that may be an indication to have a urinary catheter. Let's see. Administering preoperative medications. Again, the anesthesiologist is the one who is responsible for all medications before surgery. To relax the patient, to reduce respiratory secretions, or reduce their risk of vomiting and aspirating during surgery. That would be horrible. So if the surgery time is known, the medication is prescribed at a prearranged time. If not, it may be prescribed to give on call. So whenever, if it's in the hospital and you're working as a nurse on a surgical floor, the operating room will call up to the surgical floor and say, "We are coming to get so-and-so. Can you please give their pre-op medications?" At which time, if you were that nurse, you would be giving the medications. Something else that is frequently done is putting on anti-embolism stockings. Those are the elastic stockings that compress the veins of the legs and increase venous return to the heart. So again, I want to reiterate that in 230 I have put videos and other things in modules on oxygen and circulation, and one of the things I think that I put in there was on TED hose. So TED hose are used to prevent deep vein thrombosis and pulmonary embolism. More about preoperative client assessment. I can go on and on about this stuff. So again, what's the difference between subjective data and objective data? Subjective data is what the patient tells you. You know, they can tell you how much they weigh, but until you actually put them on the scale and find out, that's their actual weight, and that is objective data. Subjective, what they told you. Objective is what the measurement actually is. So get the health history from the patient, identify risk factors, start teaching the patient, and not only the patient but their family. If they have trouble, or they know they're going to have trouble with things at home, you start getting the social workers involved, any support groups, that type of thing, and do some patient teaching. If you have any, and I mean any young woman who comes in preoperatively, you ask them when their last menstrual period was, and you get a urine test, a urine pregnancy test. The only time that we would not do that would be is if they had their tubes tied. So urine or serum pregnancy tests should be done on female patients who have begun menstruating but have not yet gone through menopause. I cannot stress that enough. Clients are now required by law to be asked if they have signed an advance directive. An advance directive indicates their wishes for medical care if they become unable to speak for themselves. So usually, like if there is some type of preoperative checklist, you are going to see that on there that you have to ask them about their advance directives. Some people have them, some people don't. It's not mandatory that they have them. We just have to ask them if they have an advance directive. So subjective data, again, things people tell you. What's their marital status? What's the family role? What's their occupation? What type of diet are they on? What are their elimination patterns, their rest patterns? Do they use tobacco? Do they use alcohol? All of these things are things you ask them. It's not something that you know for sure. They are just telling you. It's especially important to ask if any familial problems with anesthesia, because I will mention later there is a serious life-threatening reaction that can occur resulting from certain types of anesthesia. And I will mention what that is later. Another thing you want to check for is medications. Are they on any type of anticoagulant like Coumadin? Are they diabetic and take insulin? Are they on steroids? Do they take illegal drugs? How much alcohol do you drink? I never ask people a yes or no question with alcohol. I don't ask them, do you drink alcohol? Yes or no. That's what they'll answer. Because it sounds, they don't want to answer you if the answer is yes. So I ask them, how much alcohol do you drink? How much cocaine do you use? How much marijuana do you use? How much heroin do you use? So you have to not ask a yes or no question because some people can get, could get angry with you because they'll look at you like, well, I don't do those things. But that is a better way to ask instead of do you do this or do you do that? Because if they're embarrassed or whatever, they will say no. So again, objective data is the actual data that you collect by your five senses. Objective data. You look at the skin. What's the color of their skin? Do they have any bruises? Do they have any open areas prior to going to surgery? You look for turgor, warmth, dryness. Look at their mucous membranes for color and moistness. The elderly are at greater risk for hydration problems. So remember that. Sensory assessment. Do they have any assistive devices? They might need a hearing aid for their post-op instructions to be heard or for their permit to be signed, that type of thing. And all that information needs to be passed on from pre-op to the OR to the recovery room. Because once they get to the recovery room nurse are going to be the one who are trying to wake them up. And if they have hearing aids, if they can't hear them, then it's not going to, they're not going to wake up maybe, or they're not going to understand their discharge instructions. So it's important to keep passing on information and communicating appropriately within the perioperative facility. Nervous system, can they understand the instructions? Do they have Alzheimer's? So include family members with teaching. Respiratory assessment, what's their respiratory rate? What's their respiratory pattern? Are they having difficulty breathing? That type of thing. What's their O2 sat when you use a oximeter? Do they have COPD? Have ABGs been done? What are their breath sounds like? Do they have labored breathing with or without activity? Can you hear audible wheezing? There are many, many things when you're doing an assessment. Going down to cardiovascular assessment. You listen to their heart rate. What is their apical heart rate and rhythm? Can you palpate their pulses? Do they have edema? Do they have veins sticking out on their neck, which is called jugular vein distension? If they came in, or even if they're on the surgical floor before they go to the OR, what is their gait and mobility like? What is their range of motion like? Do they have any deficits, or have they been having pain? Do they have arthritis? Do they have, those are all things you have to remember, that when people get to the operating room, they're going to be positioned in a certain way for quite a long time. So operating room nurses need to know if it's going to be possible, excuse me, if it's even going to be possible to appropriately position that patient, or what other supports and devices they might need to gather in order to make that patient more comfortable, or have less pressure areas on their skin and that type of thing. Because people who lay on an operating room table can definitely get, you know, um, get ischemic areas on their skin and have skin breakdown in the OR if they're laying there for long enough in just one position, which they do. So be mindful of that. So let's see, abdominal assessment. That's where we are. So you're going to assess the abdomen. Do they have abdominal distension? Do they have bowel sounds before they ever go to surgery? You have to note that, because if they have bowel sounds, before surgery, we want to know that, because we're assessing after surgery. Did they have, or are they having some complication from having the surgery itself or anesthesia? Because their bowel activity can slow down due to the surgery. You need to check on the diagnostic testing that was done. So they may have had an EKG because of their age. They may have had certain other types of blood tests, etc. So you have to look at all of those things. And why is the person having surgery? If they came in for some kind of repairable ligament, do you have the report available for the surgeon to look at? There are so many things that go along with preoperative nursing. If there are abnormal lab values, we want to make sure that we report those to the surgeon before and the anesthesiologist, I might add, before that person ever leaves the pre-op area. So another consideration is psychosocial. Psychosocial assessments should be carried out to gather information on how the person perceives their surgery. So most people are scared of the unknown, just like with all of these things going on at this particular time in history. It's all uncertain. It's all unknown. Nobody knows what's going to happen. So people are fearful. People are fearful of what they do not know is going to happen. So they don't know, maybe somebody's going into surgery and they have no idea after surgery how much pain this is going to cause them. How is this going to affect how my body looks? Am I going to die? What's the anesthesia like? when I get home, am I going to be able to do what I usually do, or how long am I going to be off of my job? So many things to that people think about before they go to surgery. So you have to try to figure out what their stressors are and try to relieve some of that stress. One other thing that is on this slide that was not mentioned on any other slide so far is the nutritional status of the patient. So I have seen in my career, one lady comes to mind every single time I see the word nutrition associated with surgery. It was a long time ago when I worked in the intensive care unit. I was taking care of a little lady that was going to surgery, and she was very thin, gaunt, had no teeth, and she was coming in for heart surgery. And my thought was, how nutritionally compromised she was. And I thought, how can they be taking her to surgery? But, she apparently needed heart surgery. So we did the whole, all the pre-op scrubs and everything, but she had nutritional deficits for sure. So she had her open heart surgery and she got a horrible infection. And it ended up that, like, her sternotomy, like where they cut into her sternum, did not heal well. And so she ended up having this gaping hole that you could see her heart beating through. And like her sternum was missing there. And so we had to go in and like pack that with and irrigate that. And that is one of the most memorable things in my entire career. So she was already nutritionally compromised. Then she went through surgery. So you have to really, like, try to help your team know, okay, this lady's really compromised before she's ever going to surgery. And if you've had nutrition class, what type of nutrients do people need following surgery to help them get that tissue repair? Protein, vitamin C, zinc. Those are like the three main ones that I can think of off the top of my head. But, just make sure that you are pointing out people's, deficits before they go to surgery. All right. So again, we want our patients to do well. So again, there's a lot of fears. If fears are extreme, like a fear of dying or not waking up after surgery, you need to tell the anesthesiologist. They're really good at what they do, and they can talk to the patient and try to allay some of those fears that the patient has. Because a lot of studies show that if people have a good attitude going in and they're not quite as afraid, they will do better after surgery. We've talked about most of this stuff already. Surgery can be a positive experience for people of any age that promote quality of life, but complications can occur because of previous health statuses or immobilization from surgery, normal aging processes. But remember that before somebody goes to surgery, their health problems need to be under control. So again, nutrition is on here again, and I just want to say again that emaciated individuals like that lady that I was just talking about have more trouble with infections and delayed wound healing because of their lack of nutrition. Smoking and alcohol. Smoking thickens and increases the amount of lung secretions and reduces that ciliary movement, the cilia waving back and forth to get the gunk out. Clients should avoid smoking for 24 hours before surgery. If they can quit, that's even better. Some surgeons won't even do surgery on people who need back surgery, particularly. I know some surgeons who refuse to do back surgery on people if they are smokers because they just don't heal well. Other diseases and medications, we've already talked about that as well. Chronic disorders can increase a patient's risk unless they are well controlled. So certain diseases that people have may require special monitoring. So again, if you're taking that health history, you need to pass all that information on to the other nurses and the other staff and the surgeon and the anesthesiologist. People with chronic lung disease are at greater risk for pulmonary complications like pneumonia from the anesthesia. So they need to do those turning, coughing, and deep breathing exercises and use their incentive spirometry at least 10 times per hour. So I'm not going to talk about stress, but because I've already kind of talked about stress and surgery, so I'm going to skip through that. So our goals of preoperative care, we want to reduce a person's anxiety about going into the operating room. We want to increase their knowledge about what is going on, promote the best possible physical state before they ever get through those operating room doors. So to meet those goals, we complete the admission assessment so we know what type of physical state and mental state and what kind of educational needs the person needs, that type of thing. We want to provide thorough patient education, and we want to review all the diagnostic tests that were ordered before the surgery was supposed to happen. So as far as patient education, any possible detail that you can tell people will help them be more at ease. So any medication they're going to receive, any equipment they're going to see, any instructions postoperatively for their care postoperatively should be given before surgery. So you shouldn't wait. We should not wait as nurses to wait until somebody is out of surgery to tell them that they need to cough and deep breathe, because you need to explain that beforehand, because they're not going to be they're not going to be a good audience whenever they're in pain. So, and they won't retain the information either. So demonstrate activities postoperatively, turning, coughing, deep breathing, leg exercises, and moving about. And the equipment, if you know what the equipment is. Another thing they need to be told is to tell their nurse if they're having pain. So prep for surgery, informed consent, I've already talked about that. Elimination. So have them urinate before they go to surgery, or just basically have them go to the bathroom before surgery, period. I'm going to back up to the informed consent just for 1 second, because I want to tell you that patients who are unconscious or mentally incompetent, minors, they've already received some kind of drug that alters their mental function cannot sign a consent. Another thing is that people cannot be coerced into signing a consent. So a consent has to be given voluntarily. Again, minors cannot sign for themselves unless they are emancipated. And if somebody's already had something to make them sleepy, they can't sign their consent. So make sure you get the consent before they ever have their medications. Sometimes we have to get telephone consent. In that case, if we get telephone consent from for like in a medical emergency or somebody has a power of attorney, 2 people have to hear that consent being given. Talked about the skin prep already. Dress and grooming, we usually have them in a hospital gown with all their clothes off, just depending on what the surgery is. I mean, if it's a surgery on their hand or whatever, we'll let them leave their underwear on. But if there is any metal on a bra or anything like that, it comes off. Jewelry comes off or is definitely secured to the body, but that is a danger in the OR, is to have any kind of surgery, and especially like tongue rings and things like that should never be left in. And sometimes it's hard for people to let go of those. So the nurse is completing a preoperative patient assessment, which finding indicates the greatest risk for the development of a post-op complication. I put that in there twice. Okay, you already know the answer. Sorry, my error. Good, we can skip through that. All right. So I'm not going to spend a whole lot of time. I have pre-op medications on here. So you already have a pharmacology class. So I love pharmacology, but I'm not going to go through all this because you're going to have pharmacology. But what I want to tell you about anticholinergic agents, for instance, like all of these things I'll tell you about, but anticholinergic agents, it's very important to understand what they do in the body, because once a person gets out of surgery, they're going to be saying, oh, my mouth feels like cotton. Well, you have to know why their mouth feels like cotton. It feels like cotton because they had anticholinergic agents. So atropine and Robenal are 2 very common pre-op medications given to decrease like secretions like salivation, that type of thing, so that their airway does not become compromised. That's one reason. So I'm going to go back to that slide again. The anticholinergic agent can also make people post-operatively not be able to urinate. So keep that in mind. That's really important to know that. Very important to know. Antiemetics. Again, not going to go through this. All that means is against vomiting. Zofran is probably the most commonly used medication that I used in the pre-op area anyway. Narcotic analgesics, just remember these things make people constipated, and they also depress respiratory status. So monitor the respiration. So Demerol, fentanyl, morphine. Again, the last thing on here is that pre-op meds are ordered by the anesthesiologist. Okay, sedative hypnotics. Anxiolytics are anti-anxiety drugs. That we also give hypnotics and sedatives, prior to surgery. And then there's a classification called benzodiazepines, and Versed is I've given a lot of Versed in my life for conscious sedation. All right, we're finally to intraoperative nursing. Can you believe that? So, intraoperative nursing, surgical asepsis is a condition where there's a complete absence of germs. So the instruments, the dressings, the equipment that is used for the patient and implanted into the patient. That's what the equipment means for that. So everything should be sterile that is by the patient and going to touch the operative area. So special attire is worn, as you know, and then there is a special air filtration process in the room, special ventilation system. So the instruments that are used are sterilized. So sterilization, a process where microorganisms, spores, and viruses are destroyed. I think I've told you at some point in time that you can sterilize your own stuff at home if you want to. If you have some kind of a pressure canner, you can autoclave at home. You can also just use your oven and sterilize things, but it takes a long time to sterilize in the oven. So you can boil things, you can autoclave, and that is, again, steam under pressure. And it's a cycling process. But again, not going to go through all this. I just kind of want you to be familiar with some terms. So an autoclave is that place where instruments, the stainless steel instruments and other things become sterile. Dry heat for 1 to 6 hours. That's why I was saying your oven. And then there's a liquid and vapor called ethylene oxide that is used for equipment that can't be sterilized by other methods, such as, sorry, I'm losing my train of thought. Colonoscopes for colonoscopies. So in the OR, there's the sterile team, there's a clean team. The sterile team is doing the actual operation by the patient. The clean team is on the outskirts, such as the circulating registered nurse who is actually in charge of the room and in charge of the patient care, although really the anesthesiologist or the CRNA are in charge because they are the ones who have that airway and the patient's circulatory system in their hands. So actually, they are the ones that are in charge. The skin prep is done once the patient is positioned and the anesthesiologist has given them some medication and possibly intubated them or put a laryngeal mask airway to maintain their airway. Then they're positioned and the skin is prepped. So let's see. So as far as the sterile team, again, that would include the surgeon, the surgical assistant, and a scrub person. So before they ever begin the surgery, they have to do a special hand scrub, arms, hands, and they dry with sterile towels and they put sterile gloves and sterile gowns on. Clean team members have to have clean technique or medical asepsis, and those people are the anesthesiologist or nurse anesthetist and the circulating RN. And sometimes when there are implants done, there are going to be people from companies like biomedical technicians and radiology technicians that will be in the room as well. They never enter the sterile field, but function around it and beyond it. Then there's anesthesia, who they induce the patient's amnesia and analgesia and muscle relaxation, or paralysis. So their role is to continuously monitor and evaluate the patient's responses to the anesthetic agent and the surgical procedure. CRNAs administer more than half of all anesthetics in the United States. So there you go. CRNA administers more than half of all anesthetics in the United States. So that's an advanced practice nurse. If that's something that you think you might want to do, there you go. It just takes more education. Skin prep, depending on the surgery and the institution. The patients may be asked to shower or scrub. I've already said that. With their surgical site with soap or antibacterial solution, like the chlorhexidine or betadine, before surgery in the morning of surgery. So let's see. Positioning the patient. We have to think about how we can position the patient in the OR. We have to think of where is the surgical site? How can the anesthesiologist access the patient's airway? How can the anesthesiologist monitor vital signs? Patient comfort, patient safety, all these are variables in how that person is positioned in the operating room, not just dependent on the surgical site itself. All right, so we've already covered all this, so I'm not going to go through this again, but you can look at it. Something really important right here. So, intraoperative care. Once the patient is taken back to the operating room, there is final verification of what is being done correctly. So the RN calls for a timeout. The timeout should be done when the patient is still awake so that the patient can hear and can say, no, that's not me, or no, that's not what we're doing, or whatever. So it's best that the patient is awake before the surgery gets started, and the patient should be awake during the timeout. So what is verified? We verify that we have the correct patient. We verify what procedure we're doing. We recognize which site we are doing the operation on. Want to make sure that that sterile field is maintained. We monitor the patient's I&O. The RN and the scrub tech do a sponge, sharps, and instrument count. So any needle that is thrown on the table, any extra instruments that are thrown on the table, all get counted and all get documented that it is counted. So documentation, a record is kept regarding the care that's been provided and how the patient responded to the care. So usually there are graph sheets or checklists for a little bit of space with some narrative notes about anything that the form checklist doesn't have on it. So anesthesiologists have for sure a checklist and a way to monitor document like blood pressures on a continuous basis and the I&O. talked about this. I'm just reiterating this. What are fears of anesthesia for patients? Going to sleep, not waking up, fear of the unknown, fear of acting bizarre, fear of waking up during surgery, fear of pain and other side effects, and the fear of dying. How do they determine what type of anesthesia? Again, age is a factor because different age groups respond differently to anesthetic agents. The type of surgery, the site of the surgery, the length of the surgery, and the physical and emotional state of the patient all are considered in anesthesia type. Well, I'm not quite sure what just happened there, but anyway, here I am back again. So just to talk about different anesthesia types, there is general anesthesia. So general anesthesia suspends the whole body. It acts on the central nervous system, causing loss of sensations, reflexes, and consciousness. There are several different ways that general anesthesia can be administered, and one way is with inhalation of vapors. Nitrous oxide, you are probably familiar with that. They use that in dentists' offices. But there's also furane and halophane and other gases that anesthesiologists use. They're administered along with oxygen with an oxygen mask. Always, the patients will have either an endotracheal tube or a laryngeal mask airway, and both of those are placed down the patient's throat by the anesthesiologist. Now, when I change the slide, I can't wait to see what happens. That's what I thought. Hold on. Okay, so I'm back. We can also deliver general anesthesia through IV drugs. They may be given in addition to the inhaled gases to reduce the amount of inhalant that needs to be used. So some IV drugs are listed here. The one that we gave a lot was Diprivan. I think that's spelled wrong. I know that's spelled wrong. Anyway, the greater the amount of anesthesia given, IV, the longer it takes to wake the patient. So keep that in mind also. It's not like you're going to necessarily be waking the patient up, but just so you know that if you do work in a surgical area, you may have problems waking your patient up. So always keep those reversal drugs near. I'm getting scared of changing these slides. Oh, there we go. Muscle relaxants. Increase abdominal muscle relaxation or help with endotracheal tube placement. They can cause respiratory difficulty. And again, there's a couple of them there that are used. Another type of anesthesia is called regional anesthesia, and it's used to inhibit nerve impulses to various parts of the body. So if we interrupt those nerve impulses, somebody's not going to be getting pain in a certain area, let's say. So this is what dentists use, obstetricians use before for ladies who are given birth. And one type of regional anesthetic is a spinal anesthesia. So the solution is injected into the subarachnoid space that contains cerebrospinal fluid. So this is a very important thing to know, because if your patient has a spinal anesthetic or has a lumbar puncture or a spinal tap where they're checking, the cerebral spinal fluid. People who have those types of procedures are prone to having the cerebral spinal fluid leak. So if this type of procedure is done, the patient will have to lay flat for a while and increase their fluids. And if they have a headache, you should be calling the doctor. So that's just extra information. So spinal is used for abdominal, perineal, and lower extremity surgeries. And I'm not gonna talk about this much, but just so you know, you can go over this slide right here. Read that. Okay, nursing care for persons undergoing spinals. Okay, these people are awake, number one. So you want to avoid what you say. You, it's bad to say oops when you're working in the OR. Not a good thing. The patient, again, reiterating, should lay flat for several hours post-op. Take the patient's vital signs because they could become hypotensive, and watch for a complaint of a severe headache because it indicates that spinal fluid is leaking out. So we have to keep them flat in their bed and force fluids. I'm going to go back to that. Just so you know that if they do have that severe headache and they are losing cerebral spinal fluid, there is something called a blood patch that can be done with the patient's own blood taken by phlebotomy from the patient's arm, and then the doctor will inject blood into the subarachnoid space and seal up that hole in the meninges. It's very interesting. It works very well. And other regional types of anesthetics: epidurals, peripheral nerve blocks, infiltration, and what you may be very used to or hearing about is topical anesthetic agents, like putting certain lotions on or a spray. Like they used to have a commercial on TV during the summer: stop sunburn pain with Solar Cane. So the cane drugs are the ones that are usually used for anesthetic agents. And it's CAINE, cane. Sometimes not with an E on the end. We also use topical drops, like eye drops in the eyes before cataract surgery, and those are canes as well. Conscious sedation, just to mention it again, IV conscious sedation is given during certain procedures like cataract surgery and colonoscopies to basically relax the patient. And Versed is a really common medication that has amnesic effects, so the person may not remember a lot about what went on. It's really important to monitor people's vital signs when you're doing conscious sedation. The people are still aware of their, or can be aware of their surroundings, but again, they may not remember some of the things that occurred, and they can easily be aroused by if you speak to them or touch them. So RNs are able to give conscious sedation. Other ways to do anesthesia: hypothermia, just cooling the body down, lowering the body temperature, will decrease the amount of oxygen and blood needed for tissues. And hypothermia is always used for neurological surgeries. Acupuncture is also used. I've never seen that done, so I don't know that much about it. And hypnosis, some people swear by it. I can't imagine it, but even for some relatively major surgeries, people undergo hypnosis. And then cardioplegia means basically numbing the heart. It's instilled into the coronary arteries during heart surgery. So interesting stuff. Complications. This is that there is a very rare complication that occurs due to mostly muscle relaxant as a general anesthetic, and then some of the inhalants will cause this intraoperative complication. This is very rare, and it is passed down by heredity. So anesthesiologists will always ask if, and like when we do a pre-op nursing assessment, we ask if there is any history of problems in your family with anesthesia. So malignant hyperthermia means that the body's temperature is skyrocketing. So the temperature elevates 1 degree Celsius every 5 minutes, and this is a medical emergency. So it may result in sudden death, but again, very rare. So it's a dramatic rise in the body temperature, and the temperature may get as high as 113 degrees Fahrenheit. So what do they do in this medical emergency? Well, there's a drug called dantrolene that we use. I have actually never experienced malignant hyperthermia from a nursing standpoint. I've never seen a patient go through that. But you got to get ice, and get the dantrolene going, because these people can die very quickly. So again, an emergency. Malignant hyperthermia. All right, so once we get the patient out of the OR, they've had their surgery, now they go to the recovery room. So they recover from anesthesia, which is the first post-op phase. So this is the immediate post-op phase, is when they go to the recovery room. So when the patient is transferred from the operating room table to the cart for transport to the post-anesthesia care unit. So the patient at this point is at high risk for respiratory and cardiovascular compromise. So they are escorted out of the operating room. The registered nurse and the anesthesiologist, or certified registered nurse anesthetist, will both accompany the patient to the post-anesthesia care unit. As a precaution, that's what they do. So they are responsible for giving a comprehensive report to the post-anesthesia care unit nurse, like what happened in the OR, any complications, what surgery was done, all these things. Airway management. So incentive spirometry facilitates the deep breathing, increases lung volume, and promotes coughing to clear mucus from the respiratory tract. The equipment varies in appearance. All the devices include a gauge to monitor the patient's progress visibly. Again, I want to tell you that there is a video in incentive spirometry in the module in NUR 230 under oxygenation. Please visit. Vital signs should be monitored according to the facility's policy and report abnormals to the physician, meaning anesthesiologist and the surgeon. Once they get in the post-anesthesia care unit, dressings are assessed for drainage, that type of thing. Fluid therapy, like what kind of IV fluids are they getting, and have to control pain in the patient. The nurse knows that the most important reason for controlling post-operative nausea and vomiting in the PACU is B, to prevent potential airway issues. The priority nursing intervention for the nurse in the PACU is airway management. Controlling nausea and or vomiting will prevent aspiration and ensure a patent airway. So immediately post-op, again, they go to either the recovery room or the intensive care unit. Upon admission to those units, they get a complete assessment. Evaluation of post-op patients includes following the ABCs: airway, breathing, consciousness, and circulation. Maintain the patent airway, give oxygen. Do they have a gag reflex or a swallow reflex yet? If not, they cannot drink or eat anything. When they go to the recovery room or intensive care unit, they still may be intubated or have an oral airway or nasal airway present. The pulse ox needs to be checked, and if suction is needed, that should be given until they're awake and alert. Breathing. Evaluate depth, rate, lung sounds, rhythm, and chest movement. Assess color of mucous membranes. Are they turning blue? Initiate coughing and deep breathing exercises as soon as able to respond. Chart the time the oxygen is discontinued and continue to monitor oxygen saturation levels by pulse oximetry until the patient is able to go home. Consciousness. When somebody becomes more conscious, they will start fighting that endotracheal tube. So that's a good indicator that the anesthesiologist is able to extubate them. Are they responsive to commands? Do they verbalize responses? And can they react to stimuli? As far as circulation, again, monitor their temperature, pulse, and respirations and their blood pressure every 10 to 15 minutes. Assess their heart rate, rhythm, and quality of the pulse, their apical pulse, and their peripheral pulse. Evaluate the color and warmth of their skin and nail beds. Check peripheral pulses as indicated. Let's say, for instance, they had some type of knee surgery. You want to check their pulses in their feet on both sides to see if there's any difference between possibly the operative side as compared to the unoperative side. Assess the incision and dressing, monitor drainage and output. Monitor the IV. What's the solution? What's the rate? And what does the IV site look like? Review systems. Assess neurofunction, muscular strength. Monitor any drains, tubes, the color, and the amount of the output. Check for pressure, type, and condition of the dressings. Evaluate for pain. Give them pain medication if they need it. Observe for any allergic reactions. and assess urinary output if they have a catheter in place. Again, DVT prevention, do they need SCDs or do they have TED hose on? Incentive spirometry, deep breathing and coughing. So on the left is the incentive spirometer, on the right is SCDs, and just a reminder again that they're in the module in 230 under circulation and oxygenation are videos on both of these. Post-op nursing care, returning to the nursing unit. So once I go to the surgical unit, vital signs continue, usually every 15 minutes times 4, every 30 minutes times 4, every hour times 4, every 2 hours, and then every 4 hours, and so on. And, you know, it's usually ends up being every 8 hours thereafter. So the nurse on the surgery floor monitors the IV and continues to monitor the incisional sites and any tubes or drains. Post-op orders are reviewed, and then body systems are reviewed as well. And that's just the last bullet there is what I was talking about. Review of body systems identified when body functions return and provides a guideline for further assessment. Use the times 4 factor for vital signs. Every 15 minutes times 4, every 30 minutes times 4, every 1 hour times 4, etc., etc. Keep the side rails up and the call light within reach. We don't need any accidents. We want the patient to be able to call us if they're having trouble or pain. Position on their side or with the head of the bed elevated. Again, if they vomit, there's less likelihood of aspiration. Provide an emesis basin. If they vomit, measure the amount of vomit and describe it in the nurse's notes. They may have to remain without anything to eat or drink for the first few hours post-op. The OR is cold in itself. Patients are often cold when they come out of the OR, so provide them with blankets. If you have a blanket warmer on the unit, that's wonderful. Those blankets are great. But often the patients will be shivering, and that is just a response to the anesthesia. Not all patients do that, but just so you know that some people shiver pretty dramatically. Watch for post-op complications, which can develop suddenly, like hemorrhage, for instance. If they hemorrhage, they can go into shock. So causes of post-op shock: loss of blood and body fluids, pain, inadequate ventilation, reactions to drugs or anesthetics, jamming the bed or jarring the bed against the door frame when transporting a patient, cardiac failure or cardiac arrhythmias, and moving a patient from the OR to the gurney or stretcher. All of those things can cause post-op shock. Bleeding or excessive drainage may signal post-op hemorrhage. Dressing is usually not changed but reinforced the first 24 hours. If you see drainage on a dressing, outline it, time it, and date it. Dehiscence. Try to think again what that is. Dehiscence may occur 3 days to over 2 weeks. And what is that again? Dehiscence is the ripping of the sutures. Evisceration occurs if internal organs come out. Both require prompt attention. Hypoventilation can result from drugs. People don't want to breathe deeply because they've had Demerol or morphine or whatever, anesthetics, narcotics. They don't want to breathe because they have incisional pain, or maybe they are obese, have chronic lung disease, or pressure on the diaphragm. Just remember that inadequate ventilation, inadequate breathing leads to hypoxemia, low blood oxygen. Turn, cough, and deep breathe every 2 hours. The sooner they get out of bed, the better they'll do. Listen to their breath sounds. Pain. Only the patient bearing the pain is an expert about that pain. Pain is whatever the experiencing person says it is, existing whenever he says it does. So give him some pain medicine. Everybody has their own perception of pain, and we should not be judgmental. Anesthesia does not promote urinary function. So again, I just want to say, because of some of the pre-op medications that they've been given, those anticholinergic agents, they may not be able to urinate. So check their bladder. Check them. If they don't have a urinary catheter, you need to check if they're going to the bathroom. Because if their abdomen is getting distended or their bladder is getting distended and they can't pee, you're going to have to call for a catheter order. Intake and outputs measured as long as the doctor thinks it's necessary. Again, there's that 30 cc's an hour of urine output is minimal but acceptable. Venous stasis. Another thing we teach people is leg exercises every 2 hours. The incentive spirometry should be done every hour, leg exercises every 2 hours, along with turning, coughing, and deep breathing. Already mentioned TED hose and STDs. Check for edema, check for pain in the calf with dorsiflexion. Please look up this terminology. I'm not going to tell you what it is if you don't know. I want you to look it up. It's the Hohmann sign right here. Hohmann sign. So positive Hohmann sign may indicate a thrombus, but it's not necessarily that just because they have a positive Hohmann sign does not mean they necessarily have a blood clot. Does the person need heparin or an anticoagulant? And what are the protocols in that hospital if this person is going to be on bed rest for a while? Ambulation and being mobile is so helpful in preventing complications from occurring post-operatively. So the sooner we get people up, the better off they are. So we really have to encourage them to get up and about. Just make sure that if you're getting somebody up for the very first time post-operatively, that you either have somebody else with you or that you have really assessed this patient, because you don't know how they're going to react when they stand up. Are they going to pass out on you? All those kind of things. So again, it's so important for the pre-op assessment to be done, because we need to know if that person had limitations before, so we know that if they have limitations after their surgery. Anesthesia and surgical manipulation slow paralysis. So it may take the person 3 to 4 days for the bowel activity to return. Normal bowel sounds 5 to 30 gurgles per minute. Listen for at least 1 minute per quadrant. Do not document that bowel sounds are absent unless you listen for a full 5 minutes. And that is not 5 minutes per quadrant. That is 5 minutes for the whole abdomen. Assess all 4 quadrants in this pattern. Right, left, right lower quadrant, beginning with the right lower quadrant. I don't have them in order here, do I? Right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. That is how you assess. I'm going to say it again because it's wrong on the screen. Should change that right now. I wonder if I can. So you're in the right lower quadrant. I wonder if I can change that now. Guess I can. Okay, I'll change that later. I won't do that now. But so here's the pattern. Here's the pattern for checking. Right lower quadrant, right upper quadrant, left upper quadrant, left lower quadrant. If the patient has an NG tube that is on suction, you want to turn off that suction, because if you're listening to bowel sounds, all you're going to hear is that suction. So the important thing is, if you turn the suction off, remember to turn it back on, or you might have one sick patient on your hands in an hour or two. So just be mindful, be very careful. All right, some other terms. Paralytic ileus. Sorry. Getting tired of talking. 2 solid hours of talking. All right. Paralytic ileus. The peristalsis slows or stops. So this is not a good thing. Again, this is from immobility. Activity assists GI activity. So again, it's imperative that you get your patients up post-surgically as soon as possible. Limit ice or iced beverages if they have trouble with flatus or passing gas. Encourage warm liquids. Constipation is a frequent problem following surgery, because to some people it feels really weird. It feels like they're going to rip their stitches out. That's what they tell me. So they don't want to go to the bathroom. So they should have a bowel movement within 2 or 3 days of surgery, however. Abdominal distension may be due to internal bleeding, so make sure that you are assessing that and assessing their pain level. Fluid loss during surgery through blood loss and increased insensible loss to the lungs and the skin. So they lose sodium and potassium by vomiting, by NG drainage, by blood loss. So electrolytes are often in IV fluids, like a lot of times potassium is added to IV fluids, or magnesium is added extra to IV fluids. So make sure that IV is flowing well and that the IV is not infiltrated. So what you want to educate your patient about before there's going to be discharge instructions and discharge orders from the physician, and the surgical nurse is going to want to go over discharge instructions before they go home. So what that will include is care of the wound site and dressings. Sometimes people go home with drains as well. So how do I take care of that? What medications are they going to be on? How often do I take it? When do I take it? What are the side effects, etc.? What activities are allowed or disallowed? And when can they resume their activity? What kind of diet can they be on? Are there any modifications? And what symptoms are reportable? So let's say they have a temperature of 100.4. Is that reportable? That's a fever, but maybe their surgeon doesn't, maybe that's not a parameter for them. So what is reportable? Inflammation and redness or drainage from their incision site. That's reportable. When and where to return for their follow-up appointment. And then you want to answer any questions they might have. So that is the gist of perioperative nursing. I hope that you've learned a little bit of something at least. So just remember that what is a serious potential complication of general anesthesia? Malignant hyperthermia is one, but what is the anesthesiologist in charge of? Think about that. The anesthesiologist is in charge of the patient's oxygenation, circulatory system. So those are serious potential complications of general anesthesia. Is cardiovascular depression or respiratory depression. Malignant hyperthermia is very rare, where somebody's temperature can get up to 113 degrees very fast, but again, very rare. So serious potential complication, cardiovascular depression, and malignant hyperthermia. If somebody is nutritionally compromised, does that just mean that they're, a little emaciated lady like I was talking about? No. Some people also have overnutrition and are obese, and they do not heal well sometimes either. They might have delayed wound healing, as far as being compared to somebody who is of a average weight. Make sure you know how surgeries are commonly classified. They're classified by body system, they're classified by purpose, level of urgency, and degree of risk. If you had to formulate a teaching plan for somebody who is going home on an opioid analgesic for pain management, what would you include in your teaching plan? Make sure that you know whether or not your patient has eaten or drank anything within the past 24 hours if they are going for surgery. One other term that I want to make sure that you know, that I'm sure I've said in class before, is atelectasis. Atelectasis. If a post-operative patient, does not take deep breaths and cough, their little alveoli will suffer and they will collapse upon each other, causing atelectasis. So that is the purpose of turn, cough, and deep breath exercises and incentive spirometry. So when a patient goes to the recovery room, what do you think the first thing that the nurse in recovery room does? They immediately reach for the oxygen and the pulse oximeter and check that patient's respiratory status and the oxygen saturation. Another thing I want you to remember is who can sign a consent and who can't sign a consent, and what is informed consent, and what does that entail. Is the nurse responsible for informed consent, or is the physician responsible for informed consent? If the patient's oxygen saturation level drops slightly after they come back to, let's say, their surgical room from recovery room, they have O2 sat monitor on, a pulse oximeter, and their respirations are shallow just because they're dozing a little bit, and you notice that their oxygen saturation drops from, let's say, 95% down to 91%. They look okay, they're fine as far as you can tell and as far as you can see. What would you ask that patient to do for you? I think one of the best things that you could do is to ask them to take some deep breaths, slow deep breaths, and cough. They came back from surgery, they're not quite awake, they want to sleep, they may not be feeling well, and they have had medication on board, so they're hypoventilating. So you might have to just remind them to take a deep breath once or twice, and their oxygen saturation level may come up. Just simple little maneuvers like that. So again, I'm going to upload this to YouTube and put it on the Canvas module for perioperative care. If you have any questions or concerns, please don't hesitate to contact me. And yeah, this brought back some really good memories for me. So I thank you for this opportunity.